Alright, I'm going to go ahead and start with chapter 63 here and see what I can get done as far as recording. So chapter 63 is caring for clients with ortho and connective tissue disorders. We're going to start with inflammatory disorders. So caring for clients with orthopedic and connective tissue disorders, inflammatory disorders such as arthritis, rheumatic disorders, rheumatoid arthritis, and then be sure you review that figure 63-1 in your book. Arthritis is a general condition that's characterized by inflammation and degeneration of a joint. I know you usually hear older people having arthritis, but it doesn't have to happen in just older people. But basically what it is just this inflammation and degeneration of the joint. And then you have rheumatic disorders. There's more than 100 different types. It is one of the most common orthopedic problems, obviously, with that many different types. Rheumatoid arthritis is a systemic inflammatory disorder of connective tissue, joints, characterized by chronicity, remissions, and exacerbations. So chronicity means it's a chronic problem. It's not an acute thing. Remissions means that it can go away and come back. And exacerbations are when it comes back with a vengeance, okay? Rheumatoid arthritis is believed to be autoimmune. People with rheumatoid arthritis also have a high potential for disability. You wouldn't think just having arthritis puts you, would be considered as being disabled, but it can truly cause disability. So autoimmune is when it has a strong genetic association with the HLA, human leukocyte antigen. Most often affects women ages 20 to 40, but equalizes as adults age. RA affects the small joints early in disease and the large joints later in the disease. Okay, there's a lot of information that we're getting ready to go through. The best thing I can suggest to you is to make charts and divide each thing into charts so that you can see the similarities and the differences, and that's going to be your best way to study these types of things. Oh, shoot. All right, inflammatory cycle. The synovitis increases as congestion and edema develop in the synovial membrane in the joint capsule. Synovial tissue experiences reactive hyperplasia, which is an enlargement of the tissue. You have redness and warmth occur due to vasodilation and increased blood supply. The pannus is destructive vascular granulation tissue formation occurs. The pannus destroys the cartilage, the joint capsule, and bone, and forms between the joint margins, decreasing joint mobility and leading to ankylosis. So if you remember ankylosis, that's immobility of a joint. So the disease will progress further, causing further inflammation and structural changes. Sorry about all that. Keep moving my papers here. All right. I went backwards instead of forwards. There. Assessment. All right. The onset of symptoms is acute, and joint involvement is usually bilateral and symmetric. You will have localized symptoms that include joint pain, swelling, and warmth, erythema, limited mobility, or stiffness. As the disease then progresses, clients will often experience anorexia, weight loss, malaise, just that general feeling of not feeling well, and fatigue. So hopefully you guys kind of took some time. I know you don't want to look up one word, 2 words. There's a couple of words on this page that will really, really help you remember it if you'll pause and look these things up. Other systemic features include things like vasculitis, neuropathy, scleritis, pericarditis, splenomegaly, and Sjögren's syndrome. All right, that's when you have these real dry mucous membranes. These patients also have a decreased tolerance for stress and environmental temperature changes. So they cannot go to the extreme heat or the extreme cold. It really bothers them. Rheumatoid nodules may appear. They're evident over their bony prominences and are non-tender and movable. So you can actually move these nodules over the bony prominences. Later stages include muscle wasting around the infected joints, accentuating the appearance of swelling. So if the muscle is wasting around the joints, then obviously that swelling looks so much larger. All right, is it the proximal or the distal finger joints that swell the most, showing the classic RA deformities? Again, hopefully you'll take the time to look this up. But the answer is proximal. Proximal finger joints swell the most, showing the classic RA deformities. Okay. All right, different types of deformities: swan neck deformity, boutonniere deformity, and ulnar deviation. Okay. Again, please pause the video, look this stuff up in your book. These definitions come straight from your book. I'm just going to hit some highlights here, and the rest of it I'm going to assume that you're looking up and learning this on your own. Swan neck deformity is a hyperextension of the proximal joint with fixed flexion of the distal joint. Then your boutonniere deformity is persistent flexion of the proximal joint with hyperextension of the distal joint. And then your ulnar deviation is when the fingers are deviating laterally toward the ulna. So they kind of go like, well, I can't even do it, out to the side. You can see that. All right, boutonniere deformity right here. So remember, boutonniere was hyperextension of the proximal and fixed flexion of the distal. This was swan neck, which is going to be flexion of the proximal and hyperextension of the distal. And ulnar deviation, which is where the ulnar joints drift towards the ulna. Your bones here, the ulna and the radius. All right, at this stage in the disease, clients have chronic pain that is worse when? Is it worse in the morning or worse at night? Okay, for these patients, they have chronic pain that is worse in the morning after sleeping all night, after the night's rest. The symptoms may resolve suddenly. The client will be free from joint inflammation, redness, pain, and fever. However, the symptoms will return. The inflammation will lead to more joint damage, followed by another remission. All right, RA, diagnostic findings, medical and surgical management. So diagnostic findings for RA, how are we going to diagnose? X-ray shows the joint changes and the extent of the damage. An arthrocentesis, which is aspiration of the synovial fluid, may be done. With RA, the synovial fluid will usually be cloudy, milky, or dark yellow, and it will contain inflammatory cells. Normally, an arthrocentesis, if an arthrocentesis was done on a patient, normally this would be a clear fluid that comes out. You may have an arthroscopic exam to visualize the extent of the joint damage and also obtain a sample of the synovial fluid. All right, medical and surgical management. Excuse me. Medical and surgical management, there is no cure for RA. It's really important to know because people are going to ask you that stuff. The goal is simply to decrease joint damage and inflammation before bony ankylosis occurs. Relieving discomfort, preventing and correcting deformities, and maintaining or restoring the function to the affected structure. Oftentimes this can be done with rest, systemic and local, is balanced with exercise. So you don't want them to rest all the time, and you don't want them to be exercising all the time. You have to find this fine balance between exercising and resting. But just remember that when you do rest, you need to perform localized rest, so that would be rest of the joint itself, as well as systemic rest, rest for the body itself. Okay. NSAIDs and steroids will relieve pain and inflammation. The treatment goals in decreasing joint inflammation before bony ankylosis occurs, which again is immobility of the joint. Disease-modifying anti-rheumatic drugs, or DMARDs, they help reduce the amount of damage and slow damage to other tissues. And these are things like gold preparations, methotrexate, using methotrexate. Methotrexate, though, will cause nausea and vomiting, a decreased appetite, hair loss, unusual bleeding and bruising. So you have to be careful with these drugs. Immunosuppressants, they will calm the immune system, but it also suppresses the immune system, so they all will have a higher risk for infection. These would be drugs like Imuron is an immunosuppressant. So on page 1087, there's a drug therapy table 63.1. Be sure that you look over that. Don't know that you have to know all the drugs, but I do want you to kind of be familiar with things like Celebrex. These are the drugs you hear about the most. Celebrex, Imuron, methotrexate, Humira or Enbrel, Remicade. Those are all kind of in there together. And Plaquenil. Right? All right, you've got your TNF alpha inhibitors that reduce pain and inflammation by blocking cytokines. They suppress the immune system. They're often given with methotrexate, and these are TNF alpha inhibitors are things like your Humira and Enbrel. Prosorbitherapy is when blood is taken from one arm, run through a pheresis machine to separate the plasma from the red blood cells. Plasma passes through the Prosorba column where some of the RA antibodies are removed, and then the blood is placed back into the client's other arm. It's a very interesting process that they can do. Client may have an arthroplasty or reconstruction of the joint or a synoviectomy to remove the lining of the joint. All right, so stop and think, what are some goals of the nurse caring for a client with RA? Education, medications, home care, diet. Again, I hope that you'll look in your book. These are all in the book. You'll understand it a lot better than me just sitting here telling you. But I'm just going to read off a few things I had on my notes for education, medications, home care, and diet. So education regarding general health, reducing stress. You want to educate regarding their general health, reducing their stress, decreasing the inflammatory process, preserving joint mobility. For medications, you want to teach them about aspirin. Now, they can't take aspirin if they have any ulcers or bleeding disorders. They can try NSAIDs. However, you need to educate them that those can cause upset stomach. Steroids. They're taking steroids. You need to educate that they never want to stop them abruptly. And that steroids will suppress the immune system. Instruct them to take their meds even when they're feeling better. They need to take them consistently as a maintenance medication so that it doesn't get out of control. Home care. Help with ADLs. Is anybody going to be there to help them? Okay, and then diet. They need to eat a well-balanced diet to prevent malnutrition. There is no conclusive evidence that has shown nutrition therapy to prevent attacks or cure RA. However, you will hear people talking frequently about certain foods that you want to eat. I can't even remember what they are off the top of my head, and maybe you guys will know, but I've heard different people saying, oh, well, if you have RA, you need to eat more of this and eat less of that, and that causes inflammation, and that helps reduce inflammation. And I mean, there may be a little bit of truth to that, but overall, they just need to eat a well-balanced diet. Okay, so again, you're going to have to make sure that they eat a well-balanced diet. Also need to remember that even in the acute phase, even when they're having symptoms, they still need to have some joint movement, okay? They may not want to do it, but they need to do it. All right. Degenerative joint disease. Degenerative joint disease, also referred to as osteoarthritis. You'll hear about this a lot. Excuse me. There is no remissions with OA. No systemic symptoms like malaise and fever. It's all local symptoms. More common, it's one of the most common forms of arthritis, known as the wear and tear disease, and often affects weight-bearing joints, such as hips, knees, spine, and hands, okay? Risk factors include what? If this affects weight-bearing joints, what are risk factors? Okay, hopefully you realize that risk factors are going to be increasing age, previous joint injury, obesity is a huge one, congenital and developmental disorders, hereditary factors, and decreasing bone density. These are all risk factors for OA or DJD. Primary OA occurs when there's no known etiology or no known cause. Remember, if you don't know this word, please look it up. Secondary OA is when there's an underlying disorder, such as an injury or a congenital disorder that causes the osteoarthritis. So OA begins when the cartilage that covers the bone in becomes thin, rough, and ragged. As the cartilage wears away, the joint spaces decrease, leaving the bones to get closer, and eventually they start rubbing together. In order to repair the damage, new bone does develop in the form of bone spurs, cysts, or osteophytes, bony projections, and the joint becomes deformed, leaving the client with a lot of pain and limited mobility in the joint. It is a very painful disease. Okay, here's your picture of degenerative joint disease, or OA. Here's your normal joint over here, and here's your OA joint. Okay, so you can see the breakdown, the decreased cartilage, the bony prominences, and how they're just rubbing on top of each other there. All right, assessment findings. In the early stage, you get brief joint stiffness and pain after periods of inactivity. Pain increases with activity and is relieved by rest. Okay, in the late stage, rest does not relieve the pain any longer. The client has limited mobility of the affected joint. Crepitus may be heard and felt with joint movement. And if OA affects the hands, the client may develop bony prominences to the dorsolateral surface of the interphalangeal joints. Dorsolateral, look it up if you're not sure. All right, these are going to be things like Heberdine's nodes and Bouchard's nodes. This is in the book as well, on page 1089, I believe. Heberdine's nodes are bony enlargement of the distal interphalangeal joints, and Bouchard's are bony enlargement of the proximal interphalangeal joints. X-ray is going to show disruption of joint cartilage and bony changes. So here's your pictures here, just showing you the difference. Heberdine's nodes. Remember, Heberdine's were distal interphalangeal joints, and Bouchard's, which were proximal interphalangeal joints. Again, I think a chart would really help me anyway. Medical surgical management, local rest of the affected joint. Heat application to the painful part may provide some relief. Weight loss for obese clients. I mean, that's why OA is one of the leading issues, especially here in the States, is because we have such a problem with obesity, and it's a vicious cycle. All right, there's no activity that places excessive, that you recommend no activity that places excessive stress on the affected joint. You can recommend acetaminophen, NSAIDs, and corticosteroids. Using narcotics to alleviate the pain is not recommended because it's a chronic disease and they will become chronically dependent upon the narcotic. Glucosamine and chondroitin are thought to increase the tissue function and interfere with cartilage breakdown. I know my husband has had a lot of knee issues. He's not a big guy at all, but he's constantly on his feet and working out and playing sports and things like that. And we're getting older. And so we have some of these problems. And for a good while there, he took that glucosamine and chondroitin every day, feeling like that was helping a little bit. All right, a TENS unit may help decrease the joint pain. Most clients will eventually need reconstructive joint surgery, and the most frequently replaced joints, hopefully you know, are knees and hips. All right, nursing management. Education, and more education. That is so important as nurses. All right, good posture alleviates added stress to the joints. Also, drug therapy and ADLs. All right, so criteria. Let me move here. The criteria, the rheumatoid arthritis and osteoarthritis. So I made you a little chart here. Hopefully you'll fill this in. The affected age group, the affected gender, the onset of symptoms, and joint stiffness. So, I may actually leave that. I'm going to let you guys fill that in. And you're going to need to know this stuff. So fill this in. And I think maybe I will post something or talk to you guys one day later in the week if I don't get this lecture, if I'm not able to do this lecture for you, to make sure that you get all the answers correct. This way I know that you have to stop and look this up. Okay? All right, moving on. I totally misspelled that. Temporomandibular disorder. There's no T in there. The cause is arthritis of the mandibular joint, bruxism, which is teeth grinding, or jaw dislocation. The assessment is jaw pain, headaches, tinnitus. If you don't know tinnitus, look it up. Ear pain, jaw clicking, or when the jaw locks. I'm sure you all have had friends or know people who've had this. I don't know if you can tell, but when I open and close my mouth, it definitely has a click and a lock. My husband drives him crazy when we're eating something kind of crunchy or hard for dinner or something. He'll be like, don't chew until I turn the TV on. Because we sit at opposite ends of the dinner table and he can hear my jaw clicking all the way down at the other end of the table. It drives him insane. So he'll be like, could you please stop? You know, something chewy. It really bothers him. But so I don't know if can you see that popping in where it kind of opens and locks? And my sister has the same problem. It does cause some ear pain. It does cause some headaches, causes some jaw pain often, and a lot of jaw clicking. All right, medical and surgical treatment is reconstructive surgery, or sometimes using a TENS unit. Nursing management, making sure that they have the ability to consume the food, using a mouth guard for sleep if they're grinding their teeth. I have tried that some, and I don't know if it really helps or not, but I do use it some. Okay. Moving on to gout. Now, you guys may have to remind me about that nursing management if we don't get to that, so that I don't forget to tell you those answers. You will need to know it. All right, gout is a metabolic disorder involving inflammatory reactions in the joints. Most often affects the feet, especially what? Hopefully you guys know this or will look it up for me. Most often affects the big toe. Hands, knees, and elbows. It affects more men than women and tends to be an inherited disorder. It can be a secondary disease marked by decreased renal excretion of uric acid. Gout is often characterized by hyperuricemia, which is an accumulation of uric acid in the blood and is caused by alterations in uric acid production, excretion, or both. All right, here is a picture of gout, this great significant inflammation here on the big toe. It is very, very painful. All right, primary hyperuricemia causes are going to be things like severe dieting, excessive intake of purines. And where do you find purines? You find these in organ meats, livers, shellfish, sardines. Another cause for primary hyperuricemia would be hereditary causes. All right, your secondary hyperuricemia causes would be things like abnormal purine metabolism. So it may not be that you're eating too many purines, but the fact that your body's not metabolizing. Increased rate of protein synthesis with over or under excretion of the uric acid. Increased cellular turnover. This would be in patients with cancers. And altered renal tube function related to the use of diuretics, salicylates, and excessive alcohol can also do this. And this will lead to under excretion of uric acid. So a salt of the uric acid called urate crystallizes in the body tissues, causing local inflammation and irritation. And accumulation of these deposits destroy the joint, leaving it swollen and deformed. It can also lead to renal stones. Oh, assessment findings. Assessment is often a very sudden onset with acute pain and tenderness in one joint. The joint will be red, warm, and hypersensitive to the touch. An attack can last for up to 2 weeks, which is very painful. Client will have a symptom-free period followed by another attack. Diagnosis is based on obvious clinical signs and hyperuricemia. The synovial fluid can be aspirated from the joint during arthrocentesis, and you will notice that it will contain urate crystals. Oh, I was going to tell you something else about this, but I don't know if I've already told you. Well, I'm going to wait till I get to the end. Medical surgical management. There is no cure for gout. No cure. The goal of treatment is to decrease sodium urate in the extracellular fluid so that deposits do not form. Treatment options include using uricosuric drugs that promote renal excretion of urates by inhibiting the reabsorption of uric acid in the renal tubules and decreasing the ingestion of purine. Okay. Medications include things like colchicine, allopurinol, and indomethacin. Be sure you look over this. Drug therapy chart 62.3 on table 1092. You need to look over that for sure. And you need to look at these medications in particular. All right, so stop and think. What are the major methods to prevent acute gout attack? And give some specific examples. And then provide specific teaching points for discharge teaching for an acute attack. All right, hopefully you're going to pause and look some of this stuff up yourself, but I'm going to give you a few hints anyway. Methods to prevent attacks are going to be things like decreasing the sodium urate. What you're trying to do is decrease the sodium urate in extracellular fluids so deposits don't form. So you're going to avoid foods containing purines, so your organ meats, shellfish, sardines, mushrooms, alcohol, spinach, and anchovies. I don't know if you guys know, but gout used to be called, what was it called? Well, anyway, it used to be the rich man's disease. Gout used to be the rich man's disease. You did not get gout unless you were rich. And that was because unless you were rich, you were not eating these foods. If you were not rich, you could not afford to eat organ meat, shellfish, sardines, alcohol, spinach, anchovies, things like that, things with the high purine levels. And so this used to be the rich man's disease. And other things you can do are weight loss, avoid fasting, low-carb diets, and rapid weight loss, because those inhibit uric acid excretion. You're going to increase your water intake and decrease your alcohol intake because that contributes to attacks. And chronic use of colchicine. If you use colchicine frequently, then you may need to get vitamin B12 injections. Okay. We can also use indomethacin and allopurinol to try to prevent acute gout attacks. Now, specific teaching points for discharge teaching is going to be drug therapy, the NSAIDs, ibuprofen and indomethacin, the colchicine. You give it 1 to 2 hours until the pain subsides or when nausea, vomiting, and diarrhea develops. You need to avoid salicylates. Salicylates are things like aspirin. Why do you need to avoid salicylates? Hopefully you'll remember that we just talked about the fact that these inactivate uricosuric drugs. Okay. You need to eat a diet with complex carbs that increase urate excretion. So you want diets with potatoes, whole grains, peas, vegetables, pasta. You don't want to eat organ meats, shellfish, mushrooms, alcohol. Okay? So be sure you review those things. All right. Fibromyalgia. Ooh, I still got a ton of things to talk about. Fibromyalgia. Fibromyalgia is a chronic syndrome of pain, fatigue, and sleep disturbances. The syndrome affects muscles, ligaments, and tendons. Okay, so that's important. These are pain, fatigue, and sleep disturbances that affect muscles, ligaments, and tendons. The pain receptors in the brain develop a memory of the pain and are more sensitive to these signals. The CNS sensitization lowers a client's pain threshold. So they have a lower pain threshold than normal. What would normally cause another person to have not be that painful to these clients, it's very painful. Right, the syndrome affects men, women, and children. However, middle-aged women are more prone to developing the syndrome. It does usually get better through the day and worse at night, and with weather changes, they have increased complications. For assessment, the American College of Rheumatology identifies 18 tender points on palpation that are sensitive. So if you palpate these 18 tender points, if 11 of the 18 are sensitive, then you're considered diagnostic for fibromyalgia. Diagnosis is usually made by symptoms, not necessarily tests. They run a whole lot of other tests just to rule out other issues to diagnose fibromyalgia. So there is no test to diagnose fibromyalgia. You do other tests to rule out other problems, and that's how they will diagnose it. Symptoms often include fatigue, sleep disturbances, IBS. Hopefully you know that that's irritable bowel syndrome, chronic headaches, depression, and anxiety. Okay, I have a cousin with fibromyalgia, and then my sister has fibromyalgia. And for a while I thought I had fibromyalgia, and who knows, maybe I do. I don't have time for that. Medical management. Prescribed medications include analgesics, muscle relaxants, and tricyclic antidepressants. Amitriptyline has been shown to have some success for the chronic pain. Lyrica is actually an anti-seizure medication. Is first drug approved by the FDA to treat fibromyalgia. You'll see commercials for that frequently now. Clients may also benefit from alternative therapies such as acupuncture and massage therapy. Nursing management is going to be providing emotional support and encouraging a healthy lifestyle. Fibromyalgia used to be thought of that it didn't even exist. I mean, physicians did not think that was even a real thing. And so emotional support and encouraging a healthy lifestyle were really important and continue to be very important factors. All right, bursitis. It's a very painful issue again. This is someone's elbow. All right, bursitis and inflammation of the bursa, a fluid-filled sac that cushions bone ends to enhance and gliding movement. Elbows, shoulders, knees usually. Causes include trauma or overuse, stress, infection, or secondary effects of gout and RA. Excuse me. Assessment is the painful movement of a joint. If the bursa ruptures, the area may become edematous, warm, and tender, and a distinct lump will be felt. Right? Medical and nursing management, joint rest is recommended. Prescribed medications such as salicylates, NSAIDs, and or corticosteroid preparations. Client needs education in medications and disease processes. If infection is the cause, the patient may need antibiotics. All right. Be sure that you look over pharmacological considerations on page 1094. After the pain and inflammation decrease, ongoing therapy includes mild range of motion exercises for the patient. All right. Systemic lupus erythematosus, SLE. This is the distinct rash that you will often notice with lupus. So SLE is a diffuse connective tissue disease affecting many body systems. It can affect the skin, joints, kidney, serous membranes of the heart and lungs, lymph nodes, and the GI tract. It is more common in females. In the 3rd and 4th decade, there is a strong family history. It is believed to be an autoimmune disorder where the antibodies destroy the connective tissues within the body. Assessment. SLE is known as the great imitator due to the symptoms resembling other disease processes. It's marked by many remissions and exacerbations. All right, early symptoms. Well, let me move myself here. Early symptoms include fever. Again, I hope you'll pause this and look it up yourself. Fever, weight loss, pain in the joints, muscle pain, extreme fatigue, persistent for a long time before any other symptoms develop. Okay, half of the clients experience a red butterfly-shaped rash known as the malar rash on the bridge of the nose and cheeks, and the worst gets much worse in the sunlight. Rash gets worse in the sunlight. That's what this is. This is this malar distinct butterfly rash. All right, discoid lupus erythematosus, so DLE, is a chronic rash with erythematous papules or plaques and scaling. It is most prominent appearance is a facial rash. Also can be found on the forehead, earlobes, and scalp with alopecia. If you don't know alopecia, be sure you look it up. It is a flat red rash that heals with scarring. Okay. Subacute cutaneous lupus erythematosus presents as papulosquamous lesions. This rash is and scaly. Be sure that you look through box 63-2 for all clinical manifestations of SLE on page 1095. You can have pericardial friction rub, EKG changes, enlarged spleen or lymph nodes, and weight loss. Diagnostic findings are based on symptoms and blood tests. The test that they will do is called an anti-double-stranded DNA that shows high titers of antibodies against native DNA. This test is not positive for any other autoimmune disorder, making this test SLE specific. So that's important. All right, the American College of Rheumatology has identified 11 criteria for SLE. Clients with 4 of the 11 criteria are diagnosed with probable SLE. Criteria include things like this is in the book. Hope you're going to look it up on page 1096. Includes things like a malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, pleuritis or pericarditis, renal disorders, neurologic disorders, hematologic disorders, immunologic disorders. Okay? Medical management, there is no cure for lupus. The goal is to produce remission and prevent exacerbations. So drugs include high-dose corticosteroids, NSAIDs, cytotoxic drugs, and antimalarials like Plaquenil. All right, musculoskeletal infectious disorders. Oh, osteomyelitis. I've already talked about this a little bit, but osteomyelitis is infection of the bone. It results when bacteria reach the bone via the bloodstream. Staph aureus causes 70 to 80% of bone infections. Acute localized osteomyelitis occurs when the bone is directly contaminated with bacteria from a trauma or a surgery. Microorganisms migrate just below the epiphysis. Look that up if you don't remember. Of a long bone due to increased blood supply. As the microorganisms multiply, they spread down to the shaft. Infection lingers in a necrotic state. It's difficult to penetrate the infected tissue by systemic antibiotics, therefore weakened and increased incidences of fractures. So therefore the bone gets weakened and you have an increased incidence of fractures when you have things like osteomyelitis. All right, assessment findings. Symptoms of acute infection are fever, chills, tachycardia, redness, swelling, and tenderness or pain over the affected area. You can have chronic infection, may include persistent draining sinus. So you may not have anything except it's really gross. What's called a sinus tract. So literally like a little hole in the skin, and literally where the bone has become infected, your body will try to get that infection out and will actually cause like a little cave or a little trail, almost like a little river of pus through your body tissues to the exterior skin, and it will drain, and that's called a draining sinus. It's pretty nasty. Blood work, X-ray, MRI, and bone scans may be done. What test would show an infection? All right, so increased leukocyte count, increased ESR increased ESR's eosinophil sedimentation rate. In acute osteomyelitis, they will be increased. Positive blood cultures for infective organisms. All right, ESR, that's your erythrocyte sedimentation rate, and it measures how much inflammation is in the body. All right, medical surgical management, immobilization with a cast to prevent a pathologic fracture because we know that the bone is weakened. Warm saline soaks to the affected area for 20 minutes several times daily to increase circulation. Identification of the causative organism or microorganism, initiation of IV antibiotics for up to 6 weeks, and then oral antibiotics for up to 3 months. Surgical debridement of the necrotic tissue and sequestrium to remove the infected area is usually required. You need to do a closed irrigation with saline or antibiotic solution with suction to flush out that necrotic tissue. You may have to do bone grafts to stimulate bone growth in the debrided bone once you've debrided from the infection. Muscle flaps may be used to the affected area to increase circulation, increase that blood flow, and get things healing. Okay. Structural disorders. We're getting close to the end. Osteoporosis. Osteoporosis is a loss of bone density occurring most often in older, thin-framed Caucasian women. African American women have a greater bone density, making them less susceptible. You have loss of bone substance, exceeds bone formation. The bones become porous, brittle, and fragile from bone mass and density reduction. Causes include things like family history, if you're a smoker, if you have chronic low calcium intake, excessive caffeine intake, high doses of corticosteroid use, hyperthyroidism, hyperparathyroidism, eating disorders, and malabsorption syndromes, Estrogen deficiency, which occurs with menopause, is considered the leading factor in osteoporosis among aging women that are postmenopausal. Okay? When I broke my feet, I was still pretty young, and so the physician said, you know, what precipitated this? This shouldn't be happening. We need to figure out what's going on, and referred me to get a bone density scan. And there was kind of a lot of hoopla on whether insurance was going to pay for it or not, because I was not old enough to qualify that insurance was going to pay for bone density scanning. She was concerned and said the only way we're going to know is once we do it and what happens. We'll try to make it work and see what happens. I'll have to code it however I need to code it to get insurance to pay. So I went and did the bone density scan. You know, it already had shown some bone loss. I have osteopenia, which is a milder form of osteoporosis. And so, of course, the insurance paid for it, right? So I didn't really have to be concerned with it. But, you know, so now I have to get bone scans done every couple of years. My mother also has bone scans done with osteoporosis, and all of her sisters as well. All right, so it is familial. I was not surprised when that came back positive. Assessment findings: lumbosacral pain, thoracic pain, or both from tiny compression fractures in the vertebrae. They get a loss of height, known as progressive kyphosis. I can vividly remember my grandmother shrinking and shrinking and shrinking as I was growing. Although I was growing, she was definitely still shrinking. 25% of bone loss is evident upon x-ray. Medical management will be calcium-rich and vitamin D diet to help with osteoporosis. So oral calcium with vitamin D supplements are better absorbed than those without. That's if you take oral calcium, you want to take vitamin D to help absorb the calcium. You also want to take oral calcium with meals to increase absorption and decrease GI upset. Okay, often people will quit taking their calcium because it upsets their stomach so much. Excuse me, so we have to do some education on how we can manage that so that we can still get the calcium. The disease cannot be treated directly, but management can decrease bone reabsorption. There's no treatment, but we can do management. Medications include things like biphosphonates, calcitonin, and selective estrogen receptor modifiers. So biphosphonates, an example would be Fosamax. Hopefully you guys have looked this up. The Fosamax inhibits bone reabsorption. Take once a week or monthly, which decreases your GI upset. So people will stick with it a little longer. The problem with that is remembering to take it is so infrequent. It's difficult to remember to take it. Calcitonin inhibits bone reabsorption and slows bone loss. It's usually a nasal spray, but it can also be given sub-Q. And then you have your selective estrogen receptor modifiers. These are things like Evista, and it preserves bone mass density, therefore decreasing the risk for osteoporosis. Be sure that you know these meds and how they work, okay? We've got more. We've got hormone replacement therapy. This is not used much anymore, related to the increased risk of uterine cancer and heart disease with hormone replacement therapies. We've got teriparatide or Forteo. This is given to people at high risk for fractures. It stimulates bone growth and given once a day by injection. Then you've got tamoxifen or Nolvadex. It actually reduces the risk of fractures. It's used primarily for women with breast cancer or who are at risk for breast cancer. Other treatment focuses on relieving pain and preventing injury. Nursing management is going to include things like a well-balanced diet with high in calcium and vitamin D, as well as proteins to prevent osteoporosis, promoting activity that helps bone formation, such as weight-bearing exercises, walking. Even just walking is a weight-bearing exercise. Regular weight-bearing exercises are a great thing that you can do. So one of the things that they started recommending for me immediately was to start walking. I said, but number one, I don't like to walk. I don't like to exercise. Number two, it hurt my feet. My feet hurt so much. So then what they recommended was walking like in a pool or something so that you didn't have so much of that weight, so to speak, but you didn't feel as much of that weight, so it wouldn't hurt my feet as much. But would still provide that resistance for the bones. All right, so stop and think. What diet would you recommend to a client who has recently been diagnosed with osteoporosis? Hopefully you're going to take a few minutes before I just tell you these answers. All right. We're going to recommend appropriate levels of calcium with vitamin D. Smokers are going to require more calcium and vitamin D. Vitamin D foods are things like fatty fish, egg yolks. Diets high in salt, caffeine, and sugar are associated with bone loss and should be avoided. So we're going to make sure that we have low salt, low sugar, low caffeine or decaffeinated diets. We need to add things like fruits, veggies, dark leafy greens. These are all high in calcium. Okay, so again, education is huge. All right, osteomalacia. This is a metabolic bone disease. Vitamin D deficiency causes the bones to become soft. Okay, so assessment findings for osteomalacia include bone pain and weakness, tenderness to the bones upon palpation. As the disease advances, kyphosis and a bowing of the legs will occur. Clients exhibit a waddle-like gait, making them a fall risk. So what measures should the nurse take to prevent falls? Okay, so they need to put a sign on the door if they're hospitalized. The call light needs to be within reach. Remove any floor hazards, the bedside commode, assistance with their ADLs, have the bed in the lowest position, and the bed alarms on. Okay. Now this is just showing you a picture of osteomalacia. This is a bone section. This is a solid bone matrix. And here's your weakened bone matrix with osteomalacia. All right, medical and surgical treatment include correcting the underlying cause. Where is the deficiency? That's what we're going to need to determine. Calcium, vitamin D, and phosphorus supplements, sunlight, exercise, and ambulation to promote bone formation. Nursing management is just going to be disease education. All right, Paget's disease. Paget's disease has an unknown etiology or an unknown cause. It is a chronic bone disorder characterized by abnormal bone remodeling, most often in the long bones, spine, pelvis, and skull. It occurs in adults over the age of 60. There's a disturbance in the ratio of bone formation and reabsorption. So bone reabsorption occurs when the bone is broken down so it can be replaced by new tissue. The process of bone turnover causes a mosaic pattern of bone matrix development. The new bone is not well formed but has high mineral content. This causes the bone to be weak and prone to fracture. So what are some complications with Paget's disease? Hopefully you're going to go back and look at the different types of fractures. Which type of fracture would this Paget's disease, and if a person had a fracture, what would that be constituted as? Okay, a person with Paget's disease that has a fracture will have pathological fractures. They can have paralysis from spinal cord compression, cranial nerve damage, and kidney stones. Okay, this is your normal, where's my mouse? Normal bone. Let me move this. Normal bone. And here is your Paget's disease. Okay. It's hard to tell, but you can see just this very mosaic-like, unstructured mosaic bone pattern, okay, with the bone matrix development. Therefore, no solid bone development like in here, okay. Assessment. Some clients are asymptomatic with only mild skeletal deformity. Bone tenderness upon palpation. The disease may go undiscovered until there's an x-ray for another issue that reveals the disorder. And x-rays show mosaic. Oh, excuse me. I'm sorry about that. X-ray shows a mosaic appearance to the bone structure. Okay, so that mosaic pattern. Clients without symptoms do not require treatments. Drugs include analgesics, calcitonin, or calcimer. What do you remember about calcimer? Okay, hopefully you're going to remember that calcimer inhibits bone reabsorption and slows bone loss. Biphosphonates such as actinol inhibit bone reabsorption. Okay. Surgery may be needed to repair pathologic fractures, replace damaged joints, realign deformed bones, or relieve neurologic complications. All right, disorders of the feet. Disorders of the feet. You need to understand the difference between these things. You have a hallux valgus, also called a bunion, the hammer toe, mallet toe, and often these things will result from poorly fitting shoes. So I hope you'll take the time to pause the video again, look up in the book the definitions for bunion, hammer toe, and mallet toe. And I'm going to go ahead and give you some information, but I really want you to look through your book as well. So bunions, or hallux valgus, is a deformity of the great toe at its metatarsophalangeal joint. The bunions are localized enlargements of bone and tissue on the sides and or top of the joint at either the base of the big toe or the smallest toe. Okay, so if I was actually in class with you, I would show you that I have bunion on the little toe. Most people have bunion on the big toe. Hammer toe is a flexion deformity of the proximal interphalangeal joint and may involve several toes, but they literally just kind of crinkle up. I'll show you a picture in a minute. Mallet toe is a flexion deformity at the distal joint, and often these things result from poorly fitting shoes. Can also be from arthritis or hereditary factors. All right, here's your hallux valgus, or your bunion. Okay, you can see how significantly, this is a pretty severe bunion here. Okay, and I think I've already showed you those pictures of my friend who had bunion surgery just over Christmas break, and literally they break this bone, realign it, I don't know, shave off some stuff on the bone here, some bony calluses, that callus formation, bony prominences that have formed, and realign the bone. Here's your hammer toe. So it literally, it's called hammer toe because it looks kind of like the hammer in a, like in a piano, the piano hammers. Okay. And here's your mallet toe. Whoops, mallet toe. All right. Assessment findings. Clients with bunions have pain with walking or flexing the foot, tenderness and redness of the joint. The foot deformity is very obvious, just like the pictures I showed you. With hammer toe and mallet toe, the deformity is also very obvious. Excuse me. Corns and calluses are visible, and the client complains of pain with walking. X-ray reveals the severity of the joint deformity. All right, medical and surgical management. With the bunion, there is no treatment that is pain-free or without difficulty walking. You're going to have issues when you have any kind of bunion treatment because it's going to be bunion surgery. Properly fitting shoes with a low heel will help. The deformity can be corrected with a bunionectomy. They only do 1 foot at a time usually, although somebody just recently told me that they were doing 2 feet together. I can't even remember who told me that or who had it done or what. But last I heard, they only did 1 foot at a time. I had a friend who had a bunionectomy, had 1 foot done, and it hurt so bad. She was in so much pain that she refused to get the other one done. The friend that I just had that had the bunionectomy, she only had 1 foot done. All right, hammer toe and mallet toe. You need to do exercise. Use properly fitting shoes with open toes. Use pads to protect the joints so they don't rub on the tops of the shoes. And surgery can correct malalignment. It's outpatient. You go home the same day. You just DC to home with rest, analgesics, and foot elevation. All right, nursing management is to relieve the pain and discomfort, improve mobility, instruct on the need for properly fitting shoes. I mean, that's a huge one. Properly fitting shoes. I don't know if you've ever seen pictures of ballerinas or women in China used to bind their feet so that they were tiny because that was considered to be proper, was for women to have tiny feet, and they would bind their feet so that the bones would do this certain formation. All of my kids kind of have that, like the bunion type on the pinky toe, and they're wearing soccer cleats all the time, so they curve into a more pointy toe. Soccer cleats do, and that's how their feet kind of form. Need to be sure and see client and family teaching on page 1104. And then we got bone tumors. I don't know why I'm yawning so much. I'm sorry. Benign bone tumors. Let's see. All right, benign bone tumors. Benign tumors are more common than malignant tumors. They're usually non-life-threatening but have the potential to cause fractures. These types of tumors do not metastasize and are the result of misplaced or overgrown clusters of normal bone or cartilage cells that cause the structure to enlarge and impair the function. Assessment findings are pain or discomfort that increases with weight bearing. X-ray, bone scans, and biopsy will help determine diagnosis. Medical surgical management for bone tumors include things such as treating the pain, obviously, preventing fractures. If the tumor continues to grow, they will need to perform surgery. Bone grafts may be needed to promote bone growth and healing. Splints and casts may be applied until the bone heals, and benign bone tumors can reoccur, so the client does need to be monitored closely. The nurse is responsible for educating the client on this, making sure they follow up, understand the need to follow up. All right, here's a picture of a benign bone tumor here. Okay, then we've got malignant bone tumors. Malignant tumors are either primary or secondary. Primary starts in the bone. Secondary is a cancer that originates at another location in the body, the lung, breast, kidney, and then travels to the bone. All right, malignant bone tumors are, again, I hope you'll kind of pause and check this out for yourself. But malignant bone tumors are abnormal osteoblasts or myeloblasts. Be sure you look those up so you know what they are. That exhibit rapid and uncontrollable growth. Previous exposure to radiation and toxic chemicals has been associated with some malignant bone tumors. A hereditary link with an absent or impaired tumor suppressant gene. Malignant tumors are located in distal femur or proximal fibula, and in some in the proximal humerus. All right, metastasis via the circulatory or lymphatic system. That's how it metastasizes. Assessment findings will be pathological fracture. They may be initial region the client seeks treatment. I think that I've told you guys this situation before, but I have a friend whose young daughter actually goes to high school here in town, a local high school. And several Christmases ago, it was right around Christmas time, she and her brother were just bending down to look under the tree or something at the gifts. And in doing so, she broke her leg. And they were just like, that is so odd. I mean, she wasn't hurting. Nothing was bothering her beforehand. She was athletic. But she didn't have a sprain or anything like that. And all of a sudden, she just goes to sit down and her leg breaks. Well, this is how they found a malignant bone tumor. Actually, I'm going to finish telling the rest of the story when we talk peds, because it's actually one of the pediatric things that we discuss. But this is how it was found. The initial was not the initial region. The pathological fracture was the initial region why the client sought treatment, that she had no idea until she had the fracture that she had anything wrong. All right, the client has persistent pain, swelling, and difficulty moving the extremity. They may have a limp or an abnormal gait. And by the time they experience pain, the tumor is usually spread beyond the primary site. X-ray, MRI, and bone scan will reveal abnormal bone, and biopsy reveals abnormal cells. Medical and surgical management for primary malignant tumors involve removal of the tumor by amputation of the extremity or by a wide local resection. I'm going to talk to you about that again in peds. However, limb-sparing surgery is more common. They will try to spare the limb if at all possible. This wide local resection can actually spare the limb, but they may have to go to amputation. Chemotherapy and radiation is aimed at destroying the tumor cells that escape from the original tumor site. In nursing management, this client requires extensive emotional support. Education about the disease, treatment, and prognosis is a very scary thing that happens. Okay, so if we finally finished chapter 63, now we just have peds to go, so we'll work on that next week.